Hello, this is the NICU Lives Network, and we are your hosts. I'm Melinda.
I'm Nat.
And I'm Emma. We are all NICU mothers using our lived experience to partner with health professionals to impact research, advocacy, and clinical practice.
Each week we will bring you something new. It could be a topic highlight, the latest in research, a visit to a NICU, or ways in which you can use your lived experience within the NICU to impact change. We hope you enjoy this episode.
Well, hello everyone. Thank you for joining us. This week you are with Mel and Nat. Unfortunately, Em's not able to join us, but we will see her really soon. But we have a really special guest who is joining us, and that's Professor Julee Oei. Hi, Professor. Hi, Julie.
Call me Julie. Nice to be here, and thank you for inviting me.
No, that's fantastic. Today we're going to be talking about a trial that's recruiting right now in Australian hospitals, the TORPIDO 3060. But before we jump into the trial, Julie, do you want to introduce yourself?
So good morning, Mel. Good morning, Natalie. My name is Julie, and I'm a neonatologist. I work from the Royal Hospital for Women. And my other life is I also work in addiction medicine. So I'm a visiting medical officer in the lovely town of Wagga Wagga and the Murrumbidgee Local Health District. So my two research areas are with little babies in the NICU and with families who've had problems with prenatal drug exposure. So very different groups of families, but also very rewarding with the clinical as well as the research work. So originally, you can tell I'm from Malaysia. I've been here many, many years. I hope I can talk about this project. I'm a bit flustered with this platform. It's very, very, very swanky. Well done.
No, just relaxed. Thank you.
Thank you for that introduction. It's fascinating, your work, Julie. And I was wondering, could you tell us a little bit more about the TORPIDO 3660 project?
Okay, so the TORPIDO 3060 is a project that aims to determine what the safest levels of oxygen can be for little babies below 29 weeks gestation when they first come out. So in the first 10 minutes of life, people think, 10 minutes, it doesn't really matter. But what we've shown from, other studies is that just tiny little changes of oxygen can make a profound impact on how our babies even survive. So these little babies have very immature lungs, and the minute amounts of oxygen that we give them can either increase their risk of survival or make them die. So, but we don't know what the exact level is, and this is what we're trying to work out. What is best level of oxygen that these little babies need?
So the oxygen that babies are currently getting will be one or the other. Is that what happens?
So for many, 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 many years, we were told that oxygen could only be good, so use lots of it. Everyone should be nice, pink and rosy. And then one of our group members, the famous Professor Ola Salstad from Norway and Siddharth Ramji from India, showed that term babies, the big fat babies who were deprived of oxygen before they were born, or known as hypoxic babies, actually did worse if they were resuscitated with pure oxygen, which was our standard practice. And this was because of oxidative stress and injury. But very quickly, we extrapolated Ola's results to little preterm babies. And, we like to jump onto new toys in neonatology without, really looking at the question and the patients, because little preterm babies are very different from big term babies. And what we're learning is that maybe these little babies need more oxygen than term babies to prevent damage, but we don't know how much.
And it's really important, isn't it? To understand, I guess, as a parent too, this is a really important question to be answered.
Well, around the world, yes, at least 3 million babies below 29 weeks need help breathing. And we have to refine what we give them. And what we're learning is that maybe not one size fits all. Not every baby will need the same amount of oxygen as each other.
Yeah. And that's what this trial will help answer.
Yeah, so it's a group of trials that's looking at the same research questions. So in partnership with the High-Low study in Canada, led by George Molzer, we aim to find out whether the amount of oxygen we're giving our 29-week and below babies, the sickest babies, can prevent risk of harm.
So this is an international study, Julie?
So the Torpedo 3060 is funded by the NHMRC and is currently recruiting in, how many? In 24 hospitals in 9 countries. So the majority come from Australia.
Huge.
And then we have 9 hospitals in Spain, India, and Singapore. And hopefully to start off soon is Indonesia and Japan. And, I forgot Malaysia and the US. Well, around Australia, we haven't got Perth yet, so it'd be great to have Perth in. Yes.
Yeah. And how many babies need to be recruited to get an answer?
We need a total of 1,470 babies to show a difference in the risk of death and brain injury by 20%. So currently we're up to 900. So almost there.
Yeah, absolutely.
Yeah. I was going to say that's total number globally or just for Australia, that 1,400
globally.
number?
The majority of the patients come from Australia because they've been recruiting longer, and also because of a unique process that Melinda helped us with when we were applying for ethics approval. So we did the first study 10 years ago called Torpedo 1, and that looked at the different levels of oxygen as well. But we found it very difficult to recruit babies because, these babies come up very quickly. The families are very stressed and, they're in no position to understand the study or to give adequate informed consent. So with Melinda's help, we received permission from Newcastle Ethics to conduct this study under a waiver, which is, we do it as part of routine care and with the primary outcome to be given as a waiver, so death and brain injury. We notify or discuss the study with the parents after the baby is in the nursery, and we seek consent for follow-up.
So what does that look like? So for a mum's in hospital and presenting, what does that look like for her to be entered into the trial?
Could you repeat that, Melinda?
So if a family's watching and they're in hospital, what does that look like for them if their baby's entered into the trial?
Okay, so if your baby's in the trial, what the study does is to look at different levels of oxygen that are already recommended as standard care by international guidelines. So if your baby is due to be born and is below 29 weeks gestation, the clinicians will go into the website and get a randomization or allocation, a chance allocation to whether your baby will be allocated to the low oxygen arm, which is starting at 30% oxygen, air is 21% oxygen, or the higher oxygen arm, which is 60% oxygen. But when your baby is born, we will monitor the oxygen levels very carefully with an oximeter to make sure that what oxygen levels he is getting, or he or she is getting, is adequate. So the only difference is where the oxygen dial starts at birth.
And then are there plans to expand the trials to other places in Australia? Like you mentioned Perth before, but what's the end game for you guys in terms of recruitment?
Oh, we would love to have every single one of the Australian, New Zealand units, the 28, to join. But some units have, they're very busy with their own research studies and they can't do any more, or the practice may not be what they committed to. So at the moment, we have quite a good going recruitment from the Australian studies because of this waiver process. The parents seem to accept it very well. It's part of, it's becoming almost part of routine care in our hospital.
Yeah.
So we would love more hospitals to join.
Yes.
Yes, anytime.
I think that's the really important point, and that was one of the reasons that I was really proud to be part of the project and help to gain that waiver of consent, is because it is, you know, two treatments that are already in practice. Your baby is going to get one or the other if they end up in that situation, and we need to know the answer, like which one is better. And I know as mum, and same Nat does too, being a mum, you know, going through that experience, if what you've gone through in your journey can help somebody else, it really makes such a difference. It did to my own healing too, you know, to be able to support other people through it. So it is like, it's an absolutely fantastic trial. It's definitely needed. You know, the outcomes are ones that matter to parents, and to be able to do it in this way, this process means that it can get done hopefully quicker, and, you know, better recruitment so that we can get the answer quicker. So
Exactly.
thank you for your hard work. It's absolutely amazing.
Thank you.
So it sounds like when you guys were first developing the or designing the study, so parents, carers / people with lived experience involved in that initial kind of planning or designing process? And
we had Melinda.
yeah.
Yeah.
We had the powerhouse here. Yes. So she was very involved in the ethics process, the design of the study, as well as the outcomes that we were looking for.
And what that involved for me, Nat, was that I actually drove to Newcastle and was
with
actually
William? Yes.
Yeah, with one of the other professors. I've got a little fly that wants to be in the room today. It doesn't want to go away. But I drove up and actually presented. So it was a little bit intimidating, a little bit nerve-wracking to actually be in the ethics committee. And it's quite a big committee, and it's a really big, serious process. They ask a lot of questions, and this is really new, like for waiver of consent. And probably the most important question I got was, you know, how would families feel about it? And before it got to that point, you know, had a lot of discussions with other families in terms of what this would mean. And I guess the two big points was, one, that it was treatment that was already happening, and we needed to get the answer. The other thing that parents really spoke about was how overwhelmed they are in that process. I know when my Dylan was born at 27 weeks, like if anybody in that first 24 hours had come to talk to me about anything with him, I would not have retained any information. And people did speak to me that the following day I didn't even remember them. So, you know, being asked to be part of trials. So for parents, it was, this takes the burden away, you know, from them. So, you know, I have one parent that said to me, oh, it just sounds like a no-brainer. Like, we need to get the answer. It's something my child's going to do anyway. Of course, you know, this will work. And so it was really very humbling and a big honour to be able to present to that ethics committee and really try and get parents' views and our voice across, and hopefully make a difference for other families and get the staff as well. You know, it's a new process. They have to do a waiver of consent, but, you know, that everybody was on board to help the project, which was incredible. Yeah. And that's what we want. We want more parents at the table, and that's, you know, part of the reason of doing these episodes every week, is that we want to show parents that their voice matters and that they can help have a say in making healthcare, you know, safer, better, and I guess getting important questions answered quicker. Yeah, it's definitely fantastic. So just to wrap up, Julie, is there anything else that you would like our families to know about Torpedo 3060?
Oh, definitely. Yes, share the message. Tell them that we need to finish this trial so that we can find the answers quickly. Otherwise, it'll be another 10 years, but it will benefit. And even if it doesn't show any, significant change either way, we will know how this amazing, process works to speed up all these very necessary trials for the future. Yeah. It's a huge learning experience for everyone, and we're very grateful to have all your help, all your lived experience, and all the moms and all the parents help us navigate this process. because none of us have been in this situation. I had big 4-kilo children. So this is your something that we rely on you to help us with.
And where can families find out more information if they want to learn more?
Ooh, we have a website, or they can email me anytime.
Thank you so much. I'll see if I can actually pop that
Oh, you're
up.
welcome. It's a pleasure. And thank you for introducing me to this platform. It's very swanky. Learn something new every day.
We hope to have you on future episodes. That would be awesome.
Thank
especially
you.
once the trial, and I mean, one really important thing too that we want to do on this platform is that once trials are finished, that we will be able to help share results, because that's really important.
Amazing.
Yeah. I know just recently at the Impact, the presents, we've talked about that on this show, speaking to parents, and that was one of the things really important to them, was being able to have access to results once the trial's finished.
Definitely.
We'd love to
Good
have
idea.
discuss that. So,
okay, very soon we will have results.
Thank you.
Right. Thank you, Julie.
Thank you
Bye.
very much. Bye, Melinda. Bye, Natalie. All right. Bye.
That's a wrap on another episode of the NICU Live Network. Thanks for joining us today. To stay connected, please make sure you're following us on social media and have joined our Facebook group.
And if you found value in this episode, please share, like, or comment.
We'll see you on the next episode.